and untangling the pain from pelvis to prevention. Welcome to the PID Masterclass. Today, we're diving deep into a condition that creeps silently, strikes suddenly, and can leave lasting damage. Pelvic inflammatory disease, or PID. It doesn't make the headlines like chlamydia or gonorrhea, but it's often their aftershock, and the consequences can be life-altering. Ready to trace it from the cervix to the fallopian tubes? Let's begin. What is PID anyway? Pelvic inflammatory disease is an infection of the female upper genital tract, the uterus, fallopian tubes, ovaries, and surrounding pelvic space. It starts when bacteria climb from the vagina and cervix upward into places they don't belong. The result? Inflammation, tissue damage, scarring. Sometimes, abscesses that turn the pelvis into a war zone. Not one size fits all. PID wears many disguises. Acute PID, sudden onset, noticeable symptoms less than 30 days. Subclinical PID, silent but still causes internal damage. Chronic PID lingers for more than a month, often due to TB or rare bugs like actinomycosis. The microbe mix behind the mayhem. PID is rarely a solo act, it's a polymicrobial infection, meaning multiple bacteria team up to cause trouble. The usual suspects include primary invaders, STIs, chlamydia trachomatis, Neisseria gonorrhoeae, Mycoplasma genitalium, the rising star of hard-to-treat STIs. Opportunistic friends, anaerobes like Bacteroides, aerobes like E. coli, Trichomonas vaginalis, bacteria linked to bacterial vaginosis. Together, they create an infection cocktail that inflames and scars the reproductive organs. Who's at risk? Some women are more vulnerable than others. Here's what raises the stakes: multiple sexual partners, early sexual debut, inconsistent condom use, recent IUD insertion or uterine procedures, prior STI history, being under 25, youth equals more exposed cervix equals more risk, bacterial vaginosis, possibly vaginal douching still debated. Signs, symptoms, and sneaky surprises. Common symptoms: lower abdominal or pelvic pain, often both sides, unusual vaginal discharge, yellow, green, or foul smelling, pain during sex, irregular bleeding postcoital or between periods, fever, nausea, fatigue in more severe cases. On exam, cervical motion tenderness, the infamous chandelier sign, uterine or adnexal tenderness, mucopurulent cervical discharge. When it gets serious, tubo-ovarian abscess TOA, a pus-filled pocket that can rupture, surgical emergency. Fitzhugh-Curtis syndrome, inflammation around the liver with violin string, adhesions. Patients may report right upper quadrant pain, easy to mistake for gallbladder disease. How we diagnose PID. Clinical sleuthing. There's no single test for PID. It's a diagnosis built from clinical clues. Minimum criteria: start treatment if these are present: pelvic or lower abdominal pain, and tenderness on cervical movement or uterine adnexal tenderness. Supportive findings: fever, elevated ESR or CRP, high white blood cell count, mucopurulent discharge, positive not for C. trachomatis or N. gonorrhoeae. Imaging: if diagnosis is unclear or condition is severe, ultrasound may show thickened tubes, free fluid, or abscess. MRI or CT, better for abscess evaluation. Laparoscopy, the gold standard, but rarely done unless necessary. Other conditions that can look like PID. Be careful, PID mimics many things: ectopic pregnancy, ovarian cyst rupture, appendicitis, endometriosis, urinary tract infection. Always rule these out before assuming PID, especially in reproductive age women with pain. Treating PID: fast, broad, and thorough. The goal is clear and urgent. Treat quickly to prevent long-term damage like infertility, chronic pain, or ectopic pregnancy. 1. Outpatient treatment, mild to moderate cases. Start immediately, even if you're waiting for labs. Recommended combo: ceftriaxone IM, single dose, doxycycline oral, 14 days, metronidazole oral, 14 days. Metronidazole helps knock out anaerobes and treat any coexisting BV. If allergic to cephalosporins, consider levofloxacin or moxifloxacin. 2. Inpatient treatment, severe or complicated cases. Use if can't tolerate oral meds, pregnant, TOA present, no response to outpatient treatment. Hospital regimen may include IV ceftriaxone plus IV doxycycline metronidazole or clindamycin gentamicin. 3, surgery if abscess or rupture. When meds aren't enough, drain the abscess via ultrasound or laparoscopy. In extreme cases, remove affected ovary tube. Follow-up is non-negotiable. Reassess within 48 to 72 hours to make sure symptoms are improving. Retest for STIs at 3 months. Reinfection is common. Counsel on partner testing and treatment. The long-term fallout. Why early action matters. One episode of PID is more than enough to cause damage. Infertility. Scarring of fallopian tubes equals blocked paths for sperm and eggs. Ectopic pregnancy. Fertilized egg gets stuck in a damaged tube. Chronic pelvic pain due to adhesions and nerve damage. Repeat D much more likely if partners aren't treated too. How to prevent D? Stop it before it starts. Routine STI screening, especially in young women and high-risk groups. Condom use, not perfect but protective. Prompt partner notification and treatment. Avoid unnecessary douching. Vaccinate against HPV and hepatitis B. Special populations deserve special attention. Adolescents, more vulnerable due to cervical ectopy. Offer confidential services and emphasize education. HIV-positive women may present differently. Still treat the same but monitor closely. Pregnant women, PID is rare, but if it happens, hospitalize immediately to prevent miscarriage or septic abortion. Quick recap, PID in a nutshell. PID is an infection of the upper genital tract, usually from ascending STIs. It's often polymicrobial and can present with mild or severe symptoms. Diagnosis is clinical, supported by labs and imaging. Treat immediately with broad-spectrum antibiotics. Always treat partners. Without treatment, PID can lead to infertility, ectopic pregnancy, and chronic pain. You did it. You just mastered PID. From spotting symptoms to stopping long-term complications, you're now ready to diagnose, manage, and prevent PID with confidence and clarity. Would you like a slide